Now that we've talked about the typical features of the various autoimmune diseases that may form your differential diagnosis, we can now talk about the investigations that can be done in order to clarify the autoimmune diagnosis. The overarching principle is that autoimmune testing should be targeted and based on the differential diagnosis that you have for the patient that you are investigating. This is because the diagnosis of a particular autoimmune disease is made when the patient has typical clinical features, and the diagnosis is supported by having the presence of positive specific autoimmune serology. The treatment of autoimmune diseases can involve strong immunosuppressive therapy with a multitude of side effects, particularly from steroid therapy, and thus the diagnosis must be secure beyond reasonable doubt, and there must be clear benefit to initiating therapy, such as improvement of symptoms and improvement of end organ damage. Problems arise when clinicians order batteries of tests, colloquially known as autoimmune screens or vasculitis screens, which involve a wide range of autoimmune serology tests. The problem with this is that a significant proportion of the healthy population can produce autoantibodies, and this proportion naturally rises with age. Therefore, if an autoantibody is detected in an otherwise healthy and asymptomatic individual, it is unclear if or when symptoms and manifestations of the disease will arise. And so these patients will have to have long-term follow-up in clinic when it is unclear whether these patients will even have the disease at all. And given the side effects of immunosuppressive therapy, it is very hard to justify treating a completely asymptomatic patient who happens to have positive autoimmune serology of unclear immediate significance. Therefore, we should try and avoid doing these so-called autoimmune screens and use a more targeted and nuanced approach, which I'll now discuss. When the diagnosis of an underlying autoimmune disease is suspected, we can assess for the degree of inflammatory activity by looking at the inflammatory markers, particularly the CRP and the ESR, both of which are expected to be elevated in acute and chronic inflammation respectively. Iron studies can be useful because as part of the acute phase response, ferritin tends to rise, and so an elevated ferritin would suggest active inflammation, with very high ferritin levels suggestive of an autoinflammatory disorder. The full blood count is particularly useful for a number of reasons. Cytopenias can be detected, which are associated with particular autoimmune diseases and autoinflammatory disorders, and an acute phase response, particularly an anemia or even an anemia of chronic disease, can be detected, where the mean cell volume will either be normal or trend downwards towards microcytosis over time. The white cell count differential can also be useful, in that a markedly elevated neutrophil lymphocyte ratio suggests a very active innate immune response, which may be seen in diseases such as granulomatosis with polyangiitis, and also seen in the common differential of sepsis. In contrast, a normal or relatively small elevation in the neutrophil lymphocyte ratio would be more in keeping with an underlying autoimmune disorder such as an autoimmune arthritis or connective tissue disease. Looking at the eosinophil count can also be useful to help clarify the diagnosis of eosinophilic granulomatosis with polyangiitis. Liver function tests are generally useful tests to do, as they can sometimes be elevated as part of a systemic disease, but in the case of assessing inflammatory activity, the albumin is of particular interest, as it tends to decrease as part of the acute phase response. In general, patients with high disease and inflammatory activity tend to have more symptoms of the disease, including fevers and the various disease manifestations. And altogether, these parameters give an indication of the degree of inflammatory and disease activity for the patient. Now we can discuss the more specific autoimmune serologies, which, as I've mentioned, should be ordered based on the differential diagnosis, which is based on the patient's clinical features, including the history and examination findings, and the results of basic investigations. The typical features of various autoimmune diseases has been discussed in several preceding videos, which you can check out in the link below. Understanding the typical features of the various autoimmune diseases can help you formulate an appropriate differential diagnosis, from which targeted autoimmune serology can be ordered. Firstly, if an autoimmune arthritis, particularly a seronegative spondyloarthropathy or a seropositive rheumatoid arthritis, is suspected, then the appropriate tests to order are rheumatoid factor and ACPA. These will be expected to be positive in seropositive rheumatoid arthritis and importantly negative in seronegative spondyloarthropathies. If the rheumatoid factor and ACPA are negative and the patient has clinical features of a seronegative spondyloarthropathy, a HLA-B27 can also be ordered, where the detection of this variant would support the diagnosis of a seronegative spondyloarthropathy. If polymyalgia rheumatica is suspected, then it may also be worthwhile to do a rheumatoid factor and ACPA to try and distinguish PMR from late-onset rheumatoid arthritis, which can have similar clinical presentations with large joint involvement and elevated inflammatory markers. In such a situation, you would expect PMR to have negative rheumatoid factor and ACPA, whereas seropositive late-onset rheumatoid arthritis will have a positive rheumatoid factor and/or ACPA. Secondly, if the patient has a suspected autoimmune connective tissue disease, then it would be appropriate to order an anti-nuclear antibody, or ANA. This test is able to visualize the presence of anti-nuclear antibodies which target nuclear antigens, and depending on the type of nuclear antigen has a different localization and therefore a different ANA pattern. The common ANA patterns that are observed are the homogeneous pattern, which suggests the nuclear antigen is chromatin, which would include anti-dsDNA antibodies and anti-histone antibodies. Another common pattern is the speckled ANA pattern, which would suggest the presence of autoantibodies to specific nuclear proteins, which can then be screened for in the extractable nuclear antigen, or ENA, which I'll soon discuss. The less common patterns include the centromere ANA pattern, which suggests the presence of anti-centromere antibodies, which are associated with limited cutaneous systemic sclerosis, or CREST syndrome. The nucleolar ANA pattern, which suggests the presence of anti-nucleolar antibodies, which are associated with lupus and systemic sclerosis. And depending on the cell line used, a peripheral ANA pattern can also be observed, which would suggest the presence of anti-DNA antibodies, which is associated with lupus. The ANA result is reported as a pattern as well as a titer, where the greatest dilution or the lowest concentration from which the blood sample is still able to detect the ANA pattern is reported. So for example, a low titer ANA would be something like a 1 in 80, and a very high titer ANA would be something like 1 in 1280 or 1 in 2560. The ANA is therefore a very useful test because it can see the presence of anti-nuclear antibodies, and based on the pattern can give clues to the specificity of the underlying autoantibody. Once the presence of anti-nuclear antibodies is determined, you can then move on to do a extractable nuclear antigen screen to identify the presence of autoantibodies to specific nuclear antigens. A standard ENA panel involves the following antigens: SSA or Rho52 or Rho60, which stands for Sjogren's syndrome related antigen A, and SSB, which stands for Sjogren's syndrome related antigen B. As the name implies, these antigens are associated with Sjogren's syndrome. Then there is the Smith antigen, for which anti-Smith antibodies are very specific for lupus. Anti-RNP antibodies, or ribonuclear protein, can be present in lupus or in mixed connective tissue disease, which is a overlap syndrome having features of the various autoimmune connective tissue diseases which we've discussed in a previous video. Anti-SCL70, which is also known as anti-topoisomerase 1, is associated with diffuse cutaneous systemic sclerosis, and anti-Jo1, also known as anti-histidyl tRNA synthetase antibodies, are associated with autoimmune myositis, particularly polymyositis and the antisynthetase syndrome, which we've also discussed in a previous video. In addition to the ENA panel, an anti-dsDNA antibody level can also be done, and the presence of this is suggestive of underlying lupus. C3 and C4 levels can also be done and may reveal hypocomplementemia in the case of autoimmune disease flares, particularly in lupus, where the presence of autoantibody immune complexes leads to complement activation and hence the consumption of complement. If an autoimmune myositis is suspected, particularly if the patient has muscle pain or proximal muscle weakness, then a creatine kinase level can be added on, and a marked elevation in the creatine kinase level would be suggestive of an underlying myositis. Jo1 is already part of the ENA panel and can be positive in an antisynthetase syndrome or a polymyositis. If another myositis-specific antibody is suspected to be present, particularly if the patient has signs of dermatomyositis, then it may be useful to also do a myositis line blot or an extended myositis antibody panel to look for other specific myositis antibodies, which have typical associations and are discussed in a previous video. Similarly, SCL70 is part of the ENA panel and is associated with diffuse cutaneous systemic sclerosis. However, if this is negative and the patient has clear signs of scleroderma, it may be worthwhile to add on an extended scleroderma antibody panel or scleroderma line blot to look for other autoantibodies which may also be present in overlap syndromes, such as PMSCL. Thirdly, if your differential diagnosis includes that of vasculitis, particularly a small vessel vasculitis, then it would be appropriate to test for anti-neutrophil cytoplasmic antibodies, or ANCA. Not dissimilar to the ANA, the ANCA is also reported as a pattern, where the presence of perinuclear staining or a p-ANCA pattern is suggestive of the presence of autoantibodies with specificity towards perinuclear antigens, of which the most common protein is that of myeloperoxidase or MPO. In contrast, cytoplasmic staining or a c-ANCA suggests the presence of autoantibodies to cytoplasmic antigens, of which the most common is proteinase 3 or PR3. Both MPO and PR3 can be tested to detect the level of autoantibodies to these antigens. The presence of a c-ANCA along with anti-PR3 antibodies is suggestive of underlying granulomatosis with polyangiitis, whereas a p-ANCA and anti-MPO antibodies is more suggestive of an eosinophilic granulomatosis with polyangiitis or a microscopic polyangiitis. There is another ANCA pattern known as an atypical ANCA, where there is positive fluorescence but not in a P or C ANCA pattern. Atypical ANCA may be associated with other autoimmune disorders such as inflammatory bowel disease and drug-induced vasculitis, but is usually not associated with an ANCA-associated vasculitis. If cryoglobulinemic vasculitis is suspected, then cryoglobulin testing can be done, along with complement levels as well as blood-borne virus screening. There are a few other generally useful tests that can be done when working up patients for autoimmune diseases. These are usually targeted at the common differential diagnosis for patients presenting with systemic symptoms and elevated inflammatory markers, which includes solid organ and hematological malignancies as well as infections. Firstly, thyroid function tests can be very useful because hypothyroidism and thyrotoxicosis can present with sympathetic activation and fevers, which can mimic an underlying systemic inflammatory disease. Hemotinics such as B12 and folate levels can also be useful, where a markedly elevated B12 level may be suggestive of an underlying malignancy, particularly of hematological origin. Bloodborne virus testing can also be useful because hepatitis C, as mentioned, is associated with cryoglobulinemic vasculitis, and HIV or human immunodeficiency virus can also present with fevers and systemic symptoms, particularly in the seroconversion phase, which may mimic an autoimmune disorder. And of course, sepsis must be investigated for, particularly for underlying viral or bacterial infections, as the elevated inflammatory markers and fevers in sepsis can also mimic that of autoimmune diseases. If the diagnosis is still unclear, then further testing can be done as indicated, including serum electrophoresis and free light chain assay to look for underlying plasma cell dyscrasias, which can have features which overlap with autoimmune diseases, and a bone marrow aspirate and trophine to look for the presence of underlying hematological malignancies and disorders, including hemophagocytic lymphohistiocytosis. If there's a markedly elevated ferritin, cytopenias, and the diagnosis of hemophagocytic lymphohistiocytosis is suggested, then an IL-2 receptor alpha level can be done, where an elevated level would support the diagnosis of HLH. If a periodic fever syndrome is suspected, then genetic testing for the specific diseases can be done. Imaging tests can also be useful to help clarify the diagnosis of autoimmune diseases. For example, angiography may reveal a string of beads appearance for medium-sized vessels to suggest the presence of polyarthritis nodosa. And imaging such as an MRI brain may reveal things like pachymeningitis, which would suggest neurosarcoidosis. A PET-CT scan is a useful test to do, as it will be able to detect any areas within the body which has active disease, and the location and distribution of the disease can help clarify the differential diagnosis. For example, disease within the hilar lymph nodes and the lungs bilaterally would be more suggestive of sarcoidosis, whereas diffuse disease involving the lymph nodes above and below the diaphragm would be concerning for a lymphoma. Disease affecting the vessels can suggest underlying vasculitis, and disease within a solid organ with diffuse disease through other organs may be suggestive of metastatic malignancy. However, the PET-CT scan cannot be used to confirm the diagnosis because FDG-avid disease will be seen regardless of the etiology, whether it be an autoimmune disease, malignancy, or infection. And lastly, if the diagnosis of an autoimmune disease is secure but it cannot be subtyped into a specific disease, then genome sequencing may be indicated, which can identify rare mutations affecting immune pathways to explain autoimmune diseases which do not fit into a currently recognized subtype. Once the genetic and molecular problem has been identified, specific targeted treatments can then be given or developed, known as personalized medicine. While this is still largely an experimental approach in many parts of the world, it is becoming increasingly more accessible and potentially may become part of mainstream medical practice in the near future, in the new era of personalized medicine. Now that we've discussed autoimmune testing and their indications, we can go on to summarize everything we've discussed in this video series in a practical approach to autoimmune arthritis.